This presentation, Integrative Cardiology for the Chelating Physician, was given at the Spring 2017 ACAM Chelation Therapy Training Course, chaired by Drs. Dorothy Merritt and Lynn Patrick. The talk was updated and expanded for the fall meeting, but I never gave that talk as that meeting was canceled by Hurricane Irene. Thus this voiceover PowerPoint presentation. Heavy metals lead to enzyme dysfunction and oxidative stress, the latter being the key driving force underlying vascular disease, renal disease, and many other age-related degenerative conditions. You're here to learn how to efficiently and safely remove these metal toxins from your patient's physiology, permanently improving their physiology and permanently improving their overall health. I took this course 2 decades ago. Then it was chaired by Dr. Ted Rosema, who became a mentor and a friend. Ted passed away recently, and we will miss him, but Ted accomplished his goal, and that was to ensure that chelation therapy will eventually become a standard therapy placed in the hands of every American physician. We're not there yet, but we're on our way, especially with the publication of the TAC study, which Ted helped design, and with more and more practitioners like yourselves learning this methodology. However, metals are not the only cause of oxidative stress, and chelation therapy is not a monotherapy for cardiovascular disease. Our job is not just to provide chelation therapy, but rather to move biochemical heaven and earth to make sure that our patients never set foot in the hospital for a cardiovascular challenge. Taking Ted's course 20 years ago, I learned about chelation therapy, and I learned about essential fatty acids, and I learned about homocysteine, and I learned about lipoprotein A. Actually, I learned a lot about an approach to cardiovascular disease that we now call integrative cardiology. Within integrative cardiology, and I hope that someday all cardiology will become integrative cardiology, we can use drugs, and we can send patients for procedures. I've done about 10,000 of them, and we can coordinate, if needed, coronary revascularization. We can practice this way as we were all originally taught, but now that we're thinking for ourselves, and not constrained by what our professors told us, we could add into our prior best practices nutritional repletion, nutraceutical interventions, and detoxification. We can cover all the bases of atherosclerosis prevention, which is more than just high-dose statin therapy. We will talk about statin therapy, and we will talk about a whole lot more over the next few hours. So grab a cup of coffee and let's get started. When we take an integrative approach to the problem of atherosclerosis, we first assess the patient's current pathophysiology with carotid intermediate thickness and endothelial function assessments. Risk factors give rise to endothelial dysfunction. Endothelial dysfunction gives rise to an increasing carotid IMT. IMT is the interface between physiology and anatomy. Risk factors, endothelial dysfunction, rising IMT, increased propensity to form plaque, and to experience adverse events. If we can control endothelial function and stabilize carotid IMT, applying the literature, our patients will be at very low risk for an adverse event. So that will be our physiologic goal. To do this, we need to measure and neutralize oxidative stress. If we have oxidative stress, we need to neutralize it. Now, we can throw cold water on the flames with exogenous antioxidant support, or we can increase the transcription of antioxidant enzymes by recommending our patients take NRF2 translocators. We can use drugs. Our goal is not to render the patient dependent upon drugs, but if the patient's at high risk for an adverse event, if we're practicing secondary as opposed to primary intervention, drug therapy is appropriate. Now, every drug that we use in allopathic cardiology that improves outcome is associated with a reduction in oxidative stress. When we use ACE inhibitors and ARBs, we downregulate the RAS, which downregulates NADPH oxidase, which is the key cause of superoxide generation. Statins work not by lowering cholesterol per se, but by lowering cholesterol and lowering superoxide generation via the NADPH pathway. When catecholamines auto-oxidize, they generate peroxide and superoxide. Beta blocker therapy makes sense. Blocking nuclear factor kappa beta translocation is key. Statins do that, ACE inhibitors do that. We will talk about the use of allopurinol to block superoxide generation via xanthine oxidase. We're going to be talking about colchicine to block NLRP3 activation, which is a potent generator of cytokines and thus oxidative free radical species. In the long run, and particularly want to prevent this disease, we need to help our patients remove acquired sources of non-physiologic oxidative stress. Actually, 85 to 90% of the disease with which our patients present is pretty much self-induced, overweight, sleep apnea leading to more fatigue, more overweight, heavy metals, which we're learning about in this seminar, organic pollutants, leaky gut, chronic infection. All these sources of non-physiologic oxidative stress that Mother Nature never planned on is leading to oxidative stress, lipid oxidation, and immune dysregulation. So in the long run, this is where we want to work. If our patients are ill, we need to provide antioxidant support, and we may wish to use drugs that block the generation of free radical species. So we're going to deal with oxidative stress, and we're going to control cholesterol. And I'm going to advocate the use of an HMG-CoA reductase inhibitor. It doesn't need to be a drug. We can use red yeast rice or bergamot or amla or delta-tocotrienol. We're going to complement this with berberine. Berberine activates AMP-sensitive protein kinase and works before and after inhibition of HMG-CoA reductase, and it improves insulin insensitivity and provides an independent anti-inflammatory effect. We're going to deal with the protein A. Standard allopathic cardiology ignores lipoprotein A. We will talk about how to neutralize LPA. We're going to control blood pressure, favoring agents that improve endothelial function. We're going to talk about homocysteine control, but the goal is not to lower homocysteine, it's optimize the ratio of SAMe, S-adenosine to SALI, S-adenosylhomocysteine. 300 chemical reactions depend upon adequate methylation, and the key driving force underlying methylation is the SAMe to SALI ratio. We're going to talk about lumbrokinase to deplete fibrinogen and to lyse fibrin clots. And of course, we need to optimize nutritional and hormonal status in our patients. We'll talk about unsaturated phosphatidylcholine to provide reverse cholesterol transport, and we'll touch on immune modulation, and I'll focus on the use of berberine and pentoxaline for that indication. Now, in the time allotted to me, I'm not going to be able to say all the things that I want to say. And there's an awful lot that I'd like, a lot of information that I've learned over the last 30 years that I'd like to impart to you. So we're going to have bonus coverage. So if you see Kenny the Jet Smith or Charles Barkley's picture on a slide, that means I will cover the topic more in bonus coverage. When I constructed this study, the NBA playoffs were on, and I was watching on TNT, and you know, when they have a game that's all but over and we know who's going to win, they switch you to another game and they call it bonus coverage. Thus, we're going to have bonus coverage. We'll talk about antioxidant nerve tube translocation support, ECP, lumbrokinase, coenzyme Q, carnitine and taurine, biogenic support for the tired heart, pentoxaline, what to do when you can't take a statin, K2, testosterone, berberine, organic pollutants, phosphatidylcholine, and impaired methylation. Of course, I practice integrative cardiology. That's how I describe myself. But my background is internal medicine and invasive cardiology, and I am board certified and university trained in those disciplines. Stated otherwise, I was taught, and over the first 10 years of my career, I practiced as I was taught, that the proper focus of cardiology is in anatomy. My job was to carry out a coronary angiogram to determine the severity and extent of the narrowings, and then make a recommendation as how we could best resupply oxygenated blood with a revascularization procedure. If the pattern of blockages was not amenable to revascularization, we would use drug therapy to decrease heart rate, blood pressure, contractility. Cardiology was all about dealing with supply-demand mismatched fixed lesions. And of course, this is an appropriate approach to the patient in a crisis. If you're having chest pain, you got a 99% LAD narrowing, yes, you need to be revascularized. But as we all learn, if we focus only on lesions and ignore the circulation, the abnormalities in vascular biochemistry and cell biology that cause the plaque to develop in the first place, the patient will be back with more trouble. And if we focus only on advanced lesions, we will not be preventing this disease, which is our goal for the patient and for our overall society. Now, deep to all the other risk factors is oxidative and inflammatory stress. The other risk factors relate to oxidative and inflammatory stress either as cause or consequence. About 15 years ago, we began to conceptualize atherosclerosis as a maladaptive response to the immune system, an acquired maladaptive response to what the immune system perceives as infection of the artery wall with oxidized lipids. And within this paradigm, we wish to lower lipid levels, block lipid infiltration into the vascular wall, block lipid trapping and oxidation, and to quiet down this maladaptively upregulated immune system. We're learning more recently that cells of the innate immune system, our first-line defenders, regard crystalline cholesterol in the vascular wall as a sign of danger and mount an inflammatory response. Indeed, the pathophysiology of acute gout and acute coronary disease is the same. We can block that with colchicine. Now, a key cause of oxidative stress is iron overload and heavy metals, and you're learning about chelation therapy to permanently remove these toxins from our physiology, permanently lowering the level of oxidative stress that we are experiencing. Now, I learned about chelation a little over 20 years ago from Dr. Chappell. At the time, I was practicing within the standard of care. All I was doing was invasive procedures day in and day out. And I had this really good career going until Dr. Chappell came along and kind of ruined it for me. This little old lady came in with a non-Q wave infarction. I did her heart cath. She had severe 3-vessel coronary disease, and I recommended bypass surgery. And I felt that the blockages were so tight that she needed bypass surgery before she left the hospital. And that was kind of a bold recommendation back then. The standard of care was for the patient to go home and recover and then have surgery, because surgical anesthesia then wasn't what it is today, and the mortality of bypass surgery soon after infarction was high. But these narrowings were so tight that I told her, if you don't have bypass surgery before you leave the hospital, you're going to die. So she listened to me politely and said, no, I need to go home and talk to my family. I said, okay, you're on borrowed time. Here, take this propranolol. So I saw her a month later, and I told her that she was going to die if she didn't have bypass surgery. She goes, well, I'm feeling okay, and I have more family coming in. Could you give me a bit more time? Okay, take this diltiazem. So I'd see her periodically, and each time I'd tell her that she was going to die without open heart surgery. And then about 2 years later, I was to see her, and I was getting ready to tell her that she was going to die without bypass surgery. And, well, it dawned on me that she had not yet died, and she looked really good, and she wasn't taking all my medicines. And I go, ma'am, I was so worried about you, and I wanted you to have bypass surgery, and you didn't, and you're doing so well. And she goes, well, doctor, don't be upset. You're a fine young man, but I went and I got chelation therapy. Well, ma'am, chelation therapy doesn't work. Well, Dr. Roberts, you just said I was doing better. Oh, yes. It turned out a handful of my patients with advanced heart disease went behind my back and saw Dr. Chappell and got chelation therapy and got better, and they all kind of got together and fessed up to me. So I called Dr. Chappell and asked him what he was doing, because I told him, I was told that chelation therapy doesn't work. These patients are getting better. And Dr. Chappell said, well, yeah, we were all taught that chelation therapy doesn't work, but we were not taught correctly. Well, Dr. Chappell, how does it work? Well, we think that lipid peroxidation, that was the term for oxidative stress, is the cause of heart disease. So what we're going to do, we're going to remove heavy metals that lead to lipid peroxidation and supplement our patients with antioxidant vitamins and minerals to quell this oxidative stress, this lipid peroxidation. And Dr. Chappell was right, because if we look at the TAC study, the diabetics received a greater relative benefit because diabetes generates a great deal of oxidative stress. We can see this wonderful synergy between chelation therapy, which removes metals, the cause of oxidative stress, and antioxidant vitamins that quells pre-existing oxidative stress. Dr. Chappell was right. Dr. Chappell was right about this before any other cardiologist in the Midwest. Now, metals are a key cause of oxidative stress, and that's why we apply chelation therapy. But metals are not the only cause of oxidative stress. We now have to deal with organic pollutants. Inflammation leads to oxidative stress, just as oxidative stress leads to inflammation. And now that we're seeing that many of our patients harbor genomic downregulations in their antioxidant detox defenses, such that they're canaries in the coal mine. They are less able to defend against metals, and they're more susceptible to the adverse effect of metals and other toxins. So we have lots of work to do. Now, we can utilize allopathic methodologies, but allopathic preventative cardiology has become brain-in-the-box cardiology. Nearly all cardiologists in the United States are now members of large groups. where pretty much by definition, everybody has to behave the same way. There's an advantage to that. You don't want different doctors changing your medicines each day when they round on you in the hospital, but it does stifle innovation. And basically, a consensus is reached about what is effective preventive cardiology, and that's basically what the American College of Cardiology tells us to do based upon mega studies that cost a minimum of $30 million, which means allopathic preventive cardiology will be combined to drugs and devices that generate income for big pharma or for the medical device manufacturers. This is a shame. So there's a role for statins, but the problem is they deplete CoQ, which leads to ATP deficiency, which leads to diastolic dysfunction. If you put a patient on a statin and you don't replete them with coenzyme Q, they will develop diastolic dysfunction. Statins will lower testosterone. Testosterone blunts Th1, Th17 immune dysregulation. So that's a negative, and nobody wants to have erectile dysfunction. ACE inhibitors and ARBs in general are effective and safe drugs. They can cause hyperkalemia, although we can manage that. Beta blockers have a role, but they too will deplete CoQ. They compromise conditioning, weight gain, depression, erectile dysfunction. Now, the American College of Cardiology will recommend a healthful diet and adequate sleep and exercise, and we agree. But they also say that there's no role for nutritional supplements. The American College of Cardiology says that there's no studies that support the use of nutritional intervention in cardiovascular disease. This, of course, is a statement that does not have a basis in reality, and I will present you multiple studies showing tremendous benefits of nutritional supplementation. And I don't need to tell you that, you already know that, but in the allopathic medical world, there's no role for nutritional supplements. Let's talk about the stages of atherosclerosis. Atherosclerosis begins when ApoB100 particles, that's LDL, LP, and remnants, penetrate the artery wall at sites of vulnerability. Beyond branch points, we have downregulation of NRF2, AMPK, and nitric oxide synthase. We have endothelial dysfunction, intimal thickening. Lipids can penetrate into the subintimal space. This is favored by high lipid levels, hypertension, and small particle size. Now, having LDL in the subintimal space is not pathologic because every cell of the intima has an LDL receptor. LDL is food. And if the LDL receptors are not expressed, the LDL can swim back out unless it is retained. And what happens here, the LDL will be retained by electrostatic binding to chondroitin sulfate proteoglycan within the vascular wall. In addition, phospholipase enzymes, which are upregulated in the presence of systemic inflammation, will minimally oxidize the LDL. The phospholipids will be oxidized, then the LDLs will clump together, bind onto the proteoglycan. They're trapped. They cannot swim out into the circulation. Then free radicals generated by all the resident cells within the intima will oxidize the LDL, generating oxidized LDL protein, which is not normally present in the human body. We are not tolerant to oxidized LDL. The immune system regards it as a bacteria, and we get this skewed Th1, Th17 immune response directed against oxidized LDL. Over the years, the plaque thickens with progressive lipid infiltration and macrophage infiltration. Finally, we have the terminal event, plaque rupture, at a shoulder region of the plaque where macrophages activated by interferon gamma, released by activated T helper cells, and then they generate matrix metalloproteinases that are activated by chymase and tryptase generated by activated mast cells, degrade the fibrous plaque, the atherosclerotic gruel flows into the lumen, and we have an acute coronary event. We have plaque rupture, which is an autonomous immune frenzy generating a storm of oxidative and inflammatory mediators. We want to prevent that. So let's talk in more detail about the stages of atherosclerosis. So atherosclerosis begins when LDL, LPA, and remnants traverse the endothelium and get into the subendothelial space, which of course is pathological because every cell of the intima bears an LDL receptor to recognize and internalize LDL. We have to remember that LDL is food for our cells. The problem is when we have high lipid levels, particularly small particle size, the smaller the LDL particle, the easier it is to wiggle into the artery wall. And atherosclerosis is a focal disease, not a systemic disease, because our weak points are regions of irregular shear stress. Beyond a branch point, we have irregular oscillatory shear stress, and we don't have laminar shear stress. That leads to downregulation of endothelial nitric oxide synthase, NERV2, and AMPK. So we have low generation of nitric oxide, low generation of antioxidants. These are the areas of intimal dysfunction, intimal thickening, and vulnerability. So the lipids will pour into our weak points, and this is aggravated by hypertension and environmental toxins. Metals and organic pollutants lead to oxidative stress. Cadmium leads to endothelial permeability to lipids. So we need to lower lipids. What are the causes of pathological hyperlipidemia? Poor diet, poor diet, poor diet. Low thyroid, there are genetic factors. LPA is under genetic control. Many of our patients have LDL receptor impairments, genetic hyperlipidemia. And of course, heavy metals and organic pollutants are the key acquired causes of hyperlipidemia, along with poor diet and overweight stature. And inflammation will lead to hyperlipidemia, and we can have chronic infection, which will lead to hyperlipidemia, or pseudo-infection with visceral fat. Visceral fat is hypothermic. It is hypoperfused. The visceral fat cells call in a mononuclear response that generates a great deal of inflammation that drains to the liver. We get insulin insensitivity. We get hyperlipidemia. We get fatty liver. So we need to deal with all these causes of pathologic hyperlipidemia. Now, lipids are not the problem. If lipids infiltrate the artery wall, they don't bind an active LDL receptor, they can swim back out unless they are trapped. And what happens is phospholipase enzymes, which are upregulated in the presence of systemic inflammation, will oxidize the phosphatidylcholine coating of the LDL. Now, an LDL is a sac of triglyceride and cholesterol ester. The outer core of the sac is the apolipoprotein B100, which is studded by phospholipids. And the rheologic characteristics of the LDL relates to the status of the phospholipids. And if the phospholipids are oxidized, then the LDLs will clump together. They get trapped on chondroitin sulfate, proteoglycan. They can't swim out, and then they're subject to oxidation. By free radicals. What is a free radical? It is an atom with 1 as opposed to 2 electrons in its outer shell. It is unstable and reactive. It'll snatch an electron from the adjacent atom, quenching its thirst, generating a new radical. A chain reaction will occur, damaging the region of the cell in which this oxidative assault is occurring. It will damage organelles. It will damage the cell. It will damage the tissues. It will damage the organ, leads to cardiovascular disease and kidney disease. And essentially, our patients are suffering from oxidative stress, free radical generation outweighing our antioxidant defenses. Where do these free radicals come from within the intima? Well, enzyme systems of endothelial cells, vascular smooth muscle cells, and resident macrophages, NADPH oxidase, xanthine oxidase, ACE, myeloperoxidase, cyclooxygenase, etc. They will generate free radicals and dump them across the cell membrane into the interstitial space where the LDL is trapped on proteoglycan, and that will oxidize the LDL, which can no longer escape back into circulation. So if we get this oxidative stress, we get some endothelial activation, and then mononuclear cells will come in to investigate what they think is legitimate infection, and they will upregulate and generate free radicals and inflammatory mediators. And the big problem we have is heavy metals and organic pollutants, which is causing this free radical excess within our physiology. We need to remove the metals. Now, these organic pollutants, and we'll talk about them later, are carried in the LDL, and they will activate the aryl hydrocarbon receptor and generate oxidative stress persistently. So we need to deal with metals and organic pollutants and all other causes of acquired and inappropriate oxidative stress. So we talked about where these free radicals come from and then what happens. First of all, there's a lag time. The LDL particle contains antioxidants, it contains coenzyme Q, it contains vitamin E, and they are going to be depleted. Then the phospholipids get oxidized, so the LDLs clump together, they get trapped. And then we have apolipoprotein B oxidative modification. So phospholipid oxidation creates reactive aldehydes. Malondialdehyde, lipid peroxides, this is a marker that cell membrane phospholipids are being oxidized, and this would be akin to LDL oxidation. And they form adducts with lysine and arginine of the apolipoprotein V100, creating a protein structure not normally present in human beings, which is oxidized LDL. Now, oxidized LDL protein was not present at the thymus during T cell development. We are not tolerant to oxidized LDL. It is a foreign molecule. It's toxic to endothelial cells, leading to endothelial dysfunction and increased elaboration of adhesion molecules to pull more white cells in, to generate more free radicals, to oxidize more LDL, and thus perpetuating the atherosclerotic process. Oxidized LDL is no longer food. It's not recognized by the cellular LDL receptor. Instead, it will be recognized by the CD36 and scavenger receptors on tissue macrophages, and it will be phagocytosed as if it is a microbe. And the macrophages that gobble up the oxidized LDL die, and those are foam cells, the earliest manifestation of atherosclerosis. But before these mononuclear cells die, they'll send out distress signals. There'll be a progressive infiltrate of mononuclear cells into the nascent plaque, and they're going to engulf some oxidized LDL, and they're going to chop up the oxidized LDL protein in little pieces and hightail it to the nearest lymph organ. They're going to present snippets of oxidized LDL antigenic determinants to resting T cells, and then we will generate an acquired Th1, Th17 skewed immune response to oxidized LDL protein, just as we will mount an acquired immune response to legitimate bacterial proteins. Now, we have the T cells are the drivers of atherosclerosis, and when our T cells are activated, they can take one of four pathways. In atherosclerosis, the T cells are Th1 and Th17. Their job in health is to help macrophages kill bacteria that they phagocytosed, while oxidized LDL looks to the immune system like a microbe. So atherosclerosis is Th1 and Th17 driven. Th2 cells are involved in the generation of antibodies. They do not play a role in atherosclerosis. We will not talk about them further. Treg cells promote tolerance. They quiet down the immune response. As a general rule, when we're dealing with autoimmunity and atherosclerosis, we want high Tregs, but atherosclerosis is associated with high Th1, high Th17, low Th2, and particularly low Treg. Atherosclerosis is an inflammatory process. And if we talk about pathways through which T cell differentiation is determined, keys here are the oxidative inflammatory milieu. The more inflammatory cytokines that you're experiencing, the more you're going to go Th1 and Th17. If you're experiencing oxidative stress from toxic metals and organic pollutants, you're going to go Th1 and Th17. So atherosclerosis is a dysregulated immune response to what the immune system perceives as infection of the artery wall with oxidized lipids, and we have a Th1, Th17 skewed response. What are the Th1 cytokines? Interferon gamma, interleukin 1 beta, interleukin 6, tumor necrosis factor alpha. We'll just talk about interferon gamma. It will be elaborated by activated T cells within the intima. It will cause the intima to activate to demonstrate endothelial dysfunction. Adhesion molecules are elaborated to pull more T cells in. Chemokines are released to pull more T cells in. Interferon gamma stimulates macrophages to upregulate expression of free radicals and to make more MHC2 molecules to help grab lipid particles. So, and then the interferon gamma will inhibit the proliferation of vascular wall smooth muscle. You'd think that would be a good thing because some of the plaque is composed of smooth muscle, but actually when you inhibit vascular wall smooth muscle, that will weaken the fibrous plaque and render the plaque more susceptible to plaque rupture. So all these cytokines are great. If this is a real infection, you want interferon gamma, but as we're fighting a pseudo-infection against oxidized LDL, these cytokines, particularly interferon gamma, promote progression and destabilization of the plaque. Now, I keep bringing up that atherosclerosis involves a Th1, Th17 skewed immune response. This is occurring in the artery and it's occurring systemically. If we look at the percentage of your T helper cells that are that are Th17, and the same thing would be for Th1. In people with non-coronary chest pain, it's 0.3%. Stable angina, it's 0.5%. Unstable angina, it's 2.1%. With a myocardial infarction, it's 2.3%. And we see just the opposite with respect to the percentage of your T cells systemically that are Tregs that quiet things down, going from 5.3% to 1.3%. We see low levels of Treg regulatory cytokines such as transforming growth factor beta, interleukin 10. We see rising levels of Th1 cytokines, IL-6 and CRP, and the Th17 cytokines, IL-17 and IL-23 in patients with atherosclerosis. Likewise, heart failure also involves this dysregulated immune response. Irrespective of the cause of heart failure, abnormal myocardial antigenic determinants will be expressed, and the immune system is not tolerant to them. So when you have heart failure, there's always a maladaptive immune response that damages the heart muscle. So as you go from normal to heart failure with a normal ejection fraction, heart failure with systolic dysfunction, you see a greater representation of inflammatory T cells, fewer Treg cells. Oxidative stress is the key determinant. If we take your T cells and put them in a test tube and start dribbling in oxidized LDL, we'll see a progressive decrease in Tregs and an increase in inflammatory T cells. The ease with which we can suppress Tregs in vitro with oxidized LDL relates to the current degree of activation of the atherosclerotic process. It's difficult to suppress Tregs with oxidized LDL in people with non-coronary chest pain. It becomes progressively easier with stable angina, unstable angina, and heart attack. Same thing, the ability of oxidative stress, oxidized LDL, to increase the percentage of inflammatory cells increases in lockstep. So if I have a cigarette, I might get sick to my stomach, but nothing will happen. But if someone is in the coronary care unit with unstable angina experiencing rip-roaring oxidative stress, we have them smoke a cigarette, a little bit more oxidative stress, that can precipitate an infarct. Atherosclerosis is driven by oxidative stress. The more active the atherosclerosis, the more oxidative stress you're experiencing, the more susceptible you are to an adverse event, further immune dysregulation with the administration of additional oxidative stressors. Lipid oxidation initiates and drives atherosclerosis. The greater your levels of oxidized LDL, the greater is your IMT. The greater is your IMT, the greater is your risk of forming new plaque and having an adverse event. If we look at the relative risk versus the first tercile, if you're in the second or third tercile for cholesterol LDL, you can see that it increases, but it skyrockets with high oxidized LDL. So if you are in the upper tercile for oxidized LDL, you're 4.3 times as likely to have an event over, I think, 10 years as individuals in the first tercile. So oxidative stress is the key driver. So what we need to do, we need to measure oxidative stress and deal with it. Oxidative stress means something is terribly wrong, and we can measure it. Lipid peroxides reflects oxidation of phospholipids in the cell membrane. Malondialdehyde, oxidized LDL, lipid peroxides are measuring the same thing. If we were simply going to treat with exogenous antioxidants, we would use vitamin A, vitamin E, coenzyme Q, fat-soluble antioxidants. 8-hydroxydeoxyguanosine refers to DNA that has been oxidatively damaged. When it's high, you would intervene with water-soluble antioxidants such as vitamin C and lipoic acid. Glutathione is the middle linebacker of our antioxidant detox systems. When glutathione is low, it means you're dealing with oxidative stress or a high toxic burden. So we can measure this in our patients, and pretty much every new patient that we see, well, they all know about coenzyme Q. They're taking coenzyme Q, but nonetheless, they're experiencing oxidative stress. Otherwise, they wouldn't need to see a cardiologist, because if you're not experiencing oxidative stress, you're probably not going to have cardiovascular disease. So we need to correct this situation. And everything we do that improves the outcome of the patient in allopathic or integrative cardiology boils down to improving oxidative stress. This man began working with me about 3 years ago. He had an autoimmune condition, Wegener's granulomatosis. He had recurrent coronary disease, his grafts had closed, refractory angina, he required EECP. This man was so insulin insensitive that he'd eat half an apple, his glucose would spike from 80 to 400. We began to work together, and you could see after a year, his glutathione level was rising. He still had high lipid peroxides. We kept working together. More recently, you can see that his oxidative stress markers are improving. He's now angina-free. He's feeling better. He's exercising. He can eat half an apple, and his sugar still rises, but it's no longer spiking because oxidative stress was underlying this man's insulin insensitivity, his atherosclerosis, his autoimmune condition. These are all, oxidative stress is the driver of all these inflammatory conditions. So we're going to keep working, and eventually I'm going to get everything in the green zone, and the man's going to be much healthier. Oxidative stress will give rise to inflammatory stress. We can measure inflammatory stress, fibrinogen, phospholipase A2, C-reactive protein. Myeloperoxidase is actually more of a marker of oxidative inflammatory stress. Quinolinic acid occurs when tryptophan is hijacked away from conversion into serotonin and melatonin, instead into the generation of inflammatory mediators. Oxidative stress will always give rise to inflammatory stress. What is the mechanism? Nuclear factor kappa beta translocation. When threat mediators like TNF-alpha, angiotensin 2, lipopolysaccharide ligate their receptors, a chain reaction of serine kinases is initiated that activates ICBA kinase, which degrades ICBA. That's the inhibitor of kappa beta. When ICBA kinase degrades ICBA, nuclear factor kappa beta translocates to the nucleus, leading to the transcription of pro-interleukin 1 beta, pro-interleukin 18, Th1, Th17 cytokines. This is a pathway through which we can respond to threat with amplification of our inflammatory response. Oxidative stress in the form of hydrogen peroxide will directly inactivate ICBA, leading to nuclear factor kappa beta translocation. Why is this occurring? Because the only time Mother Nature would experience oxidative stress, the only time primitive man would experience oxidative stress is when we had a legitimate infection. So our body perceives oxidative stress as another infection because that's the natural predator of mankind. We lead to ICBA deactivation, nuclear factor kappa beta translocation of the nucleus, the inflammatory response. Oxidative stress, irrespective of the etiology, will lead to inflammatory stress. So oxidative stress leads to inflammatory stress that leads to endothelial dysfunction, which we can measure with the EndoPat methodology. And again, when this is occurring in the coronary arteries of a patient with atherosclerosis, we call this endothelial dysfunction. But if you have a legitimate focal inflammation, focal infection, you want your endothelial cells to activate. You want to elaborate adhesion molecules. You want white cells to rush in. But when this is occurring in the coronary arteries, it's deleterious. We're going to call it endothelial dysfunction. And oxidative stress and inflammatory stress will give rise to endothelial dysfunction. And that brings us to the paradigm that I use when I'm thinking about atherosclerosis, which, with all great modesty, I will describe as Roberts' rules of intimal disorder. Oxidative stress gives rise to inflammatory stress, which gives rise to endothelial dysfunction, and this leads to hyperglycemia, hyperlipidemia, and immune dysregulation. Aberrancy at any one loci will adversely affect the other loci. So if your blood sugar is 600, you're going to experience oxidative stress, inflammatory stress, endothelial dysfunction, and hyperlipidemia. Correction at any one loci will favorably affect the other loci and promote health. So if we correct endothelial dysfunction, we're going to be lowering the generation of superoxide within the vascular wall. That's going to lower oxidative stress, which will lower inflammatory stress. So we want to think about every loci and what we can do to correct the abnormalities there, because if we correct, the more loci we correct, the lower the level of oxidative stress, the better will be the outcome of the patient. So in a sense, disordered vascular biochemistry that generates atherosclerosis relates to oxidative stress. Oxidative stress is the key driver of the atherosclerotic process. And in allopathic cardiology, we will use drugs such as statins and ACE inhibitors and beta blockers to lower oxidative stress. Really, the drugs that we use in allopathic cardiology that improve outcome do so by lowering oxidative stress, and those are legitimate uses for those drugs. If you have a patient with high blood pressure, you want to lower their blood pressure with an agent that lowers oxidative stress and improves endothelial function. So you're going to use an ACE inhibitor. If you use a diuretic, you're going to lower the blood pressure, but you're not going to lower oxidative stress. You're not going to improve endothelial function. So when we're thinking about lipids and blood pressure control, we want to use agents that lower oxidative stress and improve endothelial tone. Where do these free radicals come from? 2% of the oxygen that we inhale and use to generate ATP via oxidative metabolism of glucose and fatty acids is incompletely reduced to superoxide. So we're generating a free radical. Mother Nature has come up with a means of neutralizing superoxide. We have superoxide dismutase, cytoplasmic, mitochondrial, and extracellular vascular wall, which will convert superoxide to hydrogen peroxide. Hydrogen peroxide needs to be degraded to oxygen and water by catalase, glutathione peroxidase, and a class of enzymes, and this is a tough one to pronounce, peroxyredoxins. Heavy metals are a big problem. They will promote the conversion of superoxide to peroxide via the Fenton reaction to hydroxyl. Hydroxyl is 1,000 times more damaging than is superoxide. So in a sense, if our antioxidant defenses are insufficient to block the excessive generation of superoxide and peroxide, if we have a metal burden, that flaw is magnified 1,000-fold. Thus, the key importance of chelation therapy. So we're going to take this integrative approach. We can give our patients antioxidants. We can give them NRF2 translocators. We talked about the use of drugs to block the generation of free radical species. And of course, we want to deal with the lifestyle issues that brought the patient to us in the first place. So first, before we get into that, let's take an intimal look at the problem of atherosclerosis, cardiovascular physiologic diagnosis. Endothelial function. This man was part of a research program. This is his left-hander sending at rest. This is his left-hander sending after the intracorneal administration of acetylcholine. Acetylcholine is an endothelium-dependent vasodilator. If endothelial function is intact, acetylcholine leads to the elaboration of nitric oxide that diffuses to the media. You should have vasorelaxation. Conversely, acetylcholine is an endothelium-independent vasoconstrictor. As a direct chemical effect, there'll be vascular smooth muscle contraction. So whether you dilate or constrict in response to acetylcholine depends upon the level of endothelial tone. This patient had endothelial dysfunction, focally worse beyond this branch point here, so he had a tight vasospasm. So he was then treated with intracoronary nitroglycerin, which is an endothelium-independent vasodilator. The nitroglycerin is converted to nitric oxide, providing exogenous nitric oxide to cause vasodilatation. They brought the man back 4 years later, repeated his heart cath, not because he was doing poorly, but because he was part of a research protocol. And you can see that the presence of endothelial dysfunction predicted not only disease progression, but the site of disease progression. So if you have endothelial dysfunction, that is your point of greatest vulnerability. Endothelial dysfunction is the most important predictor of outcome in patients with cardiovascular disease. Now, how do we measure endothelial dysfunction? Well, here you looked at whether you dilated or constricted with acetylcholine. Those who dilated did well. Those who constricted did poorly. The cold pressor test or flow-mediated vasodilatation, which we'll talk about later. And it's not a yes or a no, it's a gradation. So the better the degree of endothelial tone, the better you're going to do. The worse your endothelial tone, the worse is your outcome. This type of study has been done in individuals with mild, moderate, severe coronary disease, normal people, people with heart failure. Endothelial function is the most important predictor of outcome. The endothelium is a massive tissue the size of the liver. It's a chemical factory, and the most important protective chemical is nitric oxide. So this takes us to Pohling's dictum. As goes the endothelium, so goes the patient. And Pohling's corollary, control the endothelium controls the cardiovascular destiny of the patient. If there's one single thing that we need to do, it is to improve endothelial tone. So there's many chemical reactions going on within the endothelium. Most important for us is the activity of nitric oxide synthase and ACE, Angiotensin Converting Enzyme. Now, ACE, we block ACE because ACE blocks the conversion of angiotensin 1 to angiotensin 2. So we get angiotensinogen generated in the liver that is converted to angiotensin 1, a weak vasoconstrictor. ACE converts to angiotensin 2, a potent vasoconstrictor. So if we want to lower blood pressure, we want to block ACE. But the lion's share of ACE is intracellular, and it is upregulated tenfold in acute coronary disease. Ligation of the angiotensin 2 receptor within the intima leads to nuclear factor kappa beta translocation, degradation of nitric oxide, and increase in superoxide within the intima. ACE has another job, and here it has another name called kinase 2, and it promotes the breakdown of bradykinin. Bradykinin is endothelial friendly, increasing the generation of nitric oxide and prostacyclin. So this enzyme, when it's present in the circulation, we want to block it to lower blood pressure, but it's also upregulated within the intima, particularly in patients with atherosclerosis. We need to block it with a fat-soluble ACE inhibitor, or if the patient can't tolerate an ACE inhibitor, an angiotensin receptor blocker. Those agents are also lipophilic and enter the endothelium. Again, ACE is upregulated in the presence of active atherosclerosis. ACE within the intima will ligate its receptor on intimal cells, leading to nuclear factor kappa beta translocation, leading to interleukin 6. Interleukin 6 enters the circulation, causes the liver to make more angiotensinogen, which enters the artery wall. We get into these vicious feedback loops. All of our mononuclear cells have receptors for angiotensin 2, leading to nuclear factor kappa beta translocation. We need to block that in the vascular wall with lipophilic ACE inhibitors, or ARBs. Now, under normal reductive circumstances, nitric oxide synthase converts arginine to nitric oxide. Nitric oxide then increases the generation of cyclic GMP, which promotes vasodilatation and reduces platelet stickiness. It also inhibits NLRP3, which we're going to be talking about later when we talk about colchicine, and it promotes ICBA. It stabilizes the inhibitor of kappa beta. So while hydrogen peroxide degrades ICBA, nitric oxide supports ICBA and blocks nuclear factor translocation, so good endothelial tone downregulates inflammation. So nitric oxide preserves ICBA and blocks inflammation. So we're sort of balancing between oxidative stress and nitric oxide. Superoxide and peroxide on the one hand and nitric oxide on the other to determine, is nuclear factor kappa beta going to translocate or not? Are we going to have an exaggerated inflammatory response within the vascular wall? So peroxide degrades ICBA, nitric oxide supports ICBA. There's a balance. And this is kind of a busy slide, but that I can summarize by saying that translocation of nuclear factor kappa beta by TNF-alpha and other Th1 cytokines is blended by exogenous and endogenous nitric oxide. Inhibition of endogenous nitric oxide leads to nuclear factor kappa beta activation. So we depend upon tonic nitric oxide generation to prevent inappropriate inflammation within the vascular wall. TNF-alpha and other Th1 cytokines leads to activation of ICBA kinase and degradation of ICBA. Transcription of ICBA is increased by exogenous and endogenous nitric oxide. Exogenous and endogenous nitric oxide stabilizes ICBA. We want high endothelial tone. If our patient is unstable and symptomatic, we can give them long-acting nitrates. This exogenous nitric oxide will also inhibit nuclear factor kappa beta translocation. Now, of course, there's downsides to exogenous nitrates, which we'll talk about a little bit later, and that they will deplete glutathione, but we can use exogenous nitrates when the patient is in trouble with concomitant antioxidant support. But above all, we want to help our patients generate their own endothelial nitric oxide to promote vasodilatation, to keep the plates from being sticky, and above all, to block inappropriate nuclear factor kappa beta translocation, which generates inflammatory cytokines. So in a reductive environment, we got plenty of glutathione. If we make more nitric oxide than we need, we can react it with glutathione and cysteine to form a ready reserve. So in a reductive environment, arginine is converted to nitric oxide, cyclic GMP, we inhibit NLRP3, and we support ICMA. Now, that makes sense when we're dealing with cardiovascular disease, but there are times when we want our endothelium to activate when we have an infection or a fracture. So we can't always be making lots of nitric oxide. There needs to be a governing principle. There may be times we want to shut off nitric oxide when we have trauma or infection. And the governor is the ratio of ADMA, asymmetric dimethylarginine, to arginine. When we have a buildup of ADMA and a high ADMA-arginine ratio, nitric oxide synthase falls apart. Instead of becoming a nitric oxide generator, instead it generates superoxide. So this is dimethylarginine. You just tack on 2 methyl groups to arginine, and that antagonizes the effect of arginine at the level of nitric oxide synthase. ADMA is generated at a constant rate with variable inactivation. All of our risk factors, via the mechanism of oxidative stress, block DDAH, which degrades ADMA. So in the presence of risk factors and oxidative stress, we have an increased ADMA to arginine ratio. It's not the absolute values, it's the ratio. When we have a high ADMA to arginine ratio, nitric oxide synthase stops generating nitric oxide and becomes a superoxide generator, which would be appropriate in infection. Because when you have an infection, you want your white cells to generate superoxide to kill the microbes. But it's inappropriate in the setting of chronic coronary disease. Now, superoxide can be dismutated by superoxide dismutase, but it reacts 3 times more rapidly with nitric oxide than it does to superoxide dismutase and forms, oh no, peroxynitrite. Peroxynitrate degrades BH4 tetrahydrobiopterin, the key cofactor for nitric oxide synthase. Nitric oxide synthase uncouples and becomes a superoxide generator. If here we're staining for superoxide within the intima of animal models of atherosclerosis, heart failure, and risk factors, you can see high levels of elaboration of superoxide in these cardiovascular conditions. So causes of endothelial dysfunction are really things that cause a high ADMA-arginine ratio such that nitric oxide synthase falls apart, stops making nitric oxide, starts making superoxide, and so phenomena that inhibit DDAH leading to a high ADMA are on this list. All the risk factors of cardiovascular disease are risk factors because they compromise endothelial function. Renal insufficiency, you can't excrete the ADMA. That's one of the links between kidney disease and cardiovascular disease. In experimental models, we can use pharmaceutical methylarginine such as LNMA to create artificial experimental endothelial dysfunction. Insufficient folates, omega-3s, magnesium, and possibly taurine cause endothelial dysfunction. I'm going to say that because supplemental taurine will improve endothelial function. Angioplasty, stent placement, and brachytherapy lead to endothelial dysfunction. Restenosis following a stent does not necessarily occur within the stent, but at the shoulder regions, at the lip of the stented region, because the stent leads to endothelial dysfunction. So the adjacent endothelium cannot make nitric oxide, and it becomes a weak link. So you'll develop a new lesion just before or just after the stent as opposed to within the stent. Deficient axon defenses, certain genetic predispositions, downregulations in nitric oxide synthase 3, or upregulations in ACE, aging, probably due to the lack of hormonal support, long-acting nitrates. When you take a long-acting nitrate, you're providing exogenous nitric oxide, but to convert the nitroglycerin to nitric oxide, use up a molecule glutathione, which leads to oxidative stress. Therefore, long-acting nitrates as a monotherapy control symptoms but worsen outcome. However, if you co-administer substances that deal with oxidative stress like N-acetylcysteine or vitamin C or vitamin E, the endothelial dysfunction brought on by administration of long-acting nitrates is extinguished. Risk factors are additive. The more risk factors you have, the greater will be your ADMA-arginine ratio, the worse will be endothelial function. 141 individuals without known cardiovascular disease, 101 with one or more risk factors, 40 age-matched controls without risk factors. You're going to measure brachial artery flow-mediated vasodilatation. You measure flow in the brachial artery, you pump up a blood pressure cuff, and you occlude the artery, and you release. As a bolus of blood rushes down the artery, the endothelial cells sense that. They should make more nitric oxide. You should vasodilate. So individuals who had no risk factors had a 7% vasodilatation. One risk factor, it's 5.8, two risk factors, 4.2, and so on and so on. The more risk factors, the more oxidative stress, the greater the inhibition of DAH, the greater the ADMA-Arginine ratio, the more likely nitric oxide will generate superoxide as opposed to nitric oxide. The worse your endothelial function, the worse you're out. We can look at ADMA as a risk factor. 53 patients undergoing angiography. Those with no significant disease and 2 to 3 vessel disease, they had similar levels of arginine. Atherosclerosis is not due to arginine deficiency. It is due to an excess of ADMA and a high ADMA ratio. You can see those that had 2 to 3 vessel disease had twice the levels of ADMA as those who had normal arteries or minimal atherosclerosis. ADMA and post-PCI event rate. 153 subjects undergoing PCI. You'll measure ADMA levels pre-intervention, stratify them into terciles, first, second, and third tercile. Record event rate over the following 16 months and relate that to their pre-PCI ADMA status. Again, the greater the level of ADMA, the greater the ADMA-Arginine ratio, the worse will be endothelial function at the time of the PCI. So major adverse cardiac event rate, as you would predict, as you go from the first to the second to the third tercile increases. Death, cardiovascular death, myocardial infarction, the need for a repeat revascularization of the stented lesion increases. Restenosis is mediated, at least in part, by endothelial dysfunction. Progression of disease, cardiovascular event rate is predicted by endothelial dysfunction. The greater ADMA level, the worse your endothelial tone, the more likely you are to have an adverse event. And this type of analysis has been done in other patient populations. No matter how you measure endothelial function, either by flow-mediated vasodilatation or the ADMA-Arginine ratio, the worse the endothelial function, the worse the endothelial biochemistry, the more likely you are to get into trouble. Arginine deficiency is not the culprit. Okay, so the sicker patients have the same level of arginine as do the healthy patients, but they have a higher ADMA level. And it's the ratio. Under normal circumstances, there's plenty of arginine available to be converted to nitric oxide. And if you have normal endothelial function and we give you arginine, nothing will happen. You'll just use it as a source of calories. But if we have a competitive inhibitor, ADMA, then your normal level of arginine is insufficient, and you have a high ADMA-Arginine ratio. In this situation, if we supplement you with additional arginine, we can push the chemical reaction back into a more homeostatic level. So if you have endothelial dysfunction, you have a high ADMA-Arginine ratio, supraphysiologic arginine dosing, cranking up your arginine level, will revert the situation. Again, remember, Mother Nature doesn't work with absolute values, it's all ratios. So if you have a high ADMA-Arginine ratio, we supplement you with arginine, we will lower the ADMA-Arginine ratio, nitric oxide synthase comes back online, you stop making superoxide, you start making nitric oxide, and the tone improves. So we can demonstrate this, looking at the effect of arginine on endothelial function. Hyperlipidemia will lead to endothelial dysfunction, and we'll talk about the mechanism a little bit later. 27 hyperlipidemic patients, their mean LDL was 238. Measure flow-mediated brachial artery enlargement, a measure of endothelial function, at baseline and after 4 weeks of placebo or arginine 7 grams 3 times a day. Randomized blinded crossover protocol. With placebo therapy, nothing happens. With arginine therapy, flow-mediated vasodilatation increases from 1.7% to 5.6% because the hyperlipidemia was leading to endothelial dysfunction by increasing the ADMA-Arginine ratio. We're not lowering the lipids, we're not lowering ADMA, but we're rectifying the ADMA-Arginine ratio. Nitric oxide synthase comes back online. You're making nitric oxide, you're not making superoxide as much, endothelial function improves. Angina refractory angina. I read this paper came out about 25 years ago, and I did not understand it at the time, but it demonstrates the powerful effect of arginine supplementation. 10 patients with refractory angina. Mean age 72, 6 are hypertensive, 4 diabetic. They'd all had prior revascularization, abnormal family perfusion scans, so they're all having ischemia. Angina at rest despite maximum medical therapy. You do baseline measurements, look at the severity of the anginal symptoms, measure cytokine and adhesion molecule levels, treat them all with arginine 3 grams 3 times a day for 3 months, repeat the lab studies and reassess angina severity. Patient tolerance was excellent. effect on adhesion molecules and inflammatory cytokines. Now, at the time, I didn't know what interleukin-1 beta was. I didn't know what E-selectin was, but they sounded like bad things. And these bad things, these markers of nuclear factor kappa beta translocation and inflammatory stress, they all fell with arginine. Clinical outcome, 7 of the 10 patients improved into functional class 2. So they're on max medical therapy, refractory angina. You give them arginine to improve endothelial function, and their angina lessens. In the 3 non-responders, the biochemical markers did not change. Maybe it was too little too late, or just not enough arginine to overcome a high ADMA-arginine ratio. Symptoms reverted to class 4 when arginine was discontinued, but arginine supplementation improved endothelial function, lowered inflammation, improved symptomatology. So how does arginine fit into here? Well, if we improve endothelial function, we're going to stop making superoxide. We're going to start making nitric oxide. We're going to lower oxidative stress. And with this, all the other drivers of atherosclerosis will improve. Aberrancy at any one loci will adversely affect the other loci. Correction at one loci will favorably affect the other loci and promote health. So we want to improve endothelial function. And we can use arginine. Studies have shown that arginine supplementation improves or restores endothelial function irrespective of the cause. It has an antioxidant effect, blocks white cell adhesion to the vessel wall, maintains the vasodilatory tone of the vessel, prevents vasospasm, blocks abnormal platelet aggregation, prevents abnormal smooth muscle cell proliferation. In coronary patients, arginine controls vasospasm, improves treadmill time. It's effective in unstable angina, refractory angina, prevents nitrate tolerance and toxicity in heart failure, ejection fraction, cardiac output, functional status increase, symptoms decrease. In claudication patients, they walk farther with fewer symptoms. In animal models of atherosclerosis, arginine supplementation protects against the initial plaque buildup, regresses pre-existent narrowings, beneficial in erectile dysfunction, and they've combined it with grapeseed extract as another antioxidant to get a better effect in erectile dysfunction. Recommendations in individuals with known atherosclerosis, 2 to 4 grams of arginine between meals 3 times a day, combining it with eNOS upregulators, antioxidants, taurine, methylfolate for greater clinical effect. So we have a low threshold for recommending arginine to our patients. There's really no downsides. The only paper that showed a negative effect of arginine, they had patients with an acute MI, and they gave them arginine, and it did not help. And in that situation, the nitric oxide that was generated would be rapidly converted to peroxynitrite because they're experiencing a superoxide storm. Had they repeated the study with concomitant administration of antioxidants, they would have had a different outcome. A second study was done of arginine in acute MI, and it did not show a negative effect. So the only reason not to give arginine is if the patient is experiencing severe, profound oxidative stress that you're otherwise not going to address. But otherwise, arginine is of value in essentially all cardiovascular syndromes. Causes of endothelial dysfunction includes high LDL cholesterol. I used to say that cholesterol would not harm us until it's oxidized, but that's not the case. High LDL will lead to endothelial dysfunction and oxidative inflammatory stress. Enrichment of the endothelial cell membrane with LDL cholesterol, particularly at the level of the caveoli. These are invaginations in the endothelial cell membrane. These are areas where arginine is exchanged for nitric oxide. This is where eNOS hangs out. Compromises nitric oxide synthase generation and leads to endothelial dysfunction and oxidative stress. So enrichment of the endothelial cell membrane at the level of caveoli with LDL leads to the generation of caveolin, which sequesters nitric oxide synthase. Hyperlipidemia leads to sequestration of nitric oxide synthase, and we make less nitric oxide. We start making superoxide. If we incubate endothelial cells with LDL and oxidized LDL, we decrease nitric oxide generation, particularly with oxidized LDL, but even with native LDL. So hyperlipidemia leads to endothelial dysfunction. And we know that if we have endothelial dysfunction, we're going to get nuclear factor kappa beta translocation. So hyperlipidemia leads to endothelial dysfunction, which leads to inflammatory and oxidative stress. And of course, this is part of Mother Nature's plan because she views hyperlipidemia as something of value when we're dealing with infection. Those of us with genetic hyperlipidemia, our ancestors were better able to handle the threat to mankind posed by infection. I'll elaborate on that principle a little bit later. So how do we measure endothelial function? Well, we could do a heart cath and give you acetylcholine, and I remember doing that when I was a younger physician. This was the only way we could measure endothelial function. We have easier ways now. Brachial artery flow-mediated vasodilatation. If you read papers on endothelial dysfunction, they'll talk about brachial artery flow-mediated vasodilatation. So what you do, you take an ultrasound and measure the diameter of the brachial artery. You pump up a blood pressure cuff and choke the artery for a couple minutes, and you release. As a bolus of arterial blood flows down the artery, mechanoreceptors on the endothelial cells will sense that, and they'll start making nitric oxide. You should vasodilate, and you can demonstrate percent increase in brachial artery diameter. We tried doing this in the office. It's technically difficult. It's not, covered by insurance, so it's not really practical, and it's not being done anymore. Instead, we do pulse amplitude tonometry with the EndoPat device. What you do, you put a clip on the finger, and that's measuring pulsatile flow. You pump up a blood pressure cuff, and you're going to choke the artery, and then you're going to release. This patient had poor endothelial tone. You can see there was no compensatory vasodilatation. Then you're comparing this to the contralateral arm. So this is normal flow. You choke it. This patient does not increase. They have endothelial dysfunction. This patient has this has high endothelial tone, this vasodilatory rebound. So you're measuring the experimental artery, the arm you're treating, versus the concomitant arm, and look at the ratio. And this EndoPat measurement has been shown to correlate with intracoronary acetylcholine. So our practical gold standard for endothelial function testing will be the EndoPat pulse amplitude tonometry, and that's what we use in the office. Here's a nice clinical case. BH was 81 when we first met in 2006. Physically active, trim, non-hypertensive man who bore amalgam fillings. And in 2006, he had a normal stress perfusion study. I saw him in 2009. He's asymptomatic. He has a normal 8-minute stress echo. His LDL was slightly high. We dropped it to 109 with red yeast rice extract. His LPA is normal. Homocysteine looks good. Fibrinogen and CRP look good. Low free testosterone, but he had had 3 prior biopsies for variable PSA, so we didn't put him on testosterone. Antioxidant defenses were at the 32nd percentile, so we put him on an antioxidant program. He needs knee surgery in 10. We do a stress test. It looks good. 3 years later, in 2013, he comes in with stable, effort-induced, nitrogen responsive chest discomfort. He walks 6.5 minutes on the treadmill. He has chest tightness, ST depression, and hypokinesis in the LAD distribution. He, by then, was in his mid to late 80s. He was not really excited about an angiogram, so we did a non-invasive angiogram, a CT angiogram, that returned with a 50 to 70% left main narrowing, moderate to severe, mid-LAD, circ and RCA were okay. So we had moderate left main and LAD disease, which normally would call for angiography and revascularization. But this man's in his late 80s, and he's clinically stable, and his daughter is one of us, an integrative physician who could provide her dad with chelation therapy at very low cost. So his baseline endothelial function was okay. The cutoff is like 1.8. He's 2.7. He gets 60 treatments with magnesium EDTA using the ACAM protocol, getting rid of metals that cause oxidative stress. And oxidative stress leads to endothelial dysfunction. And look what happened. His endothelial tone was supranormal. He held the record for the best EndoPat score in our practice for many years. Someone else just topped him at 6.0. But his endothelial function was okay, and now it's supraphysiologic. It's fantastic, and this is going to stabilize his arteries. And clinically, he's doing well, and he's now in his late 80s with stable angina, great endothelial tone. I don't think this man needs to have open heart surgery, which of course would be associated with a high risk at his age range. So endothelial function is key. Proper endothelial function maintains vasodilatory tone, resistance to platelet activation, resistance to white cell infiltration, maintains endothelial redox status in a reduced level. We want a reduced endothelial status, not an oxidized endothelial status, and lowers endothelial inflammation, because oxidative stress would lead to inflammatory stress. Dealing with oxidative stress will lower inflammatory stress in the intima or within any other organ system. So endothelial dysfunction is really malactivation of the endothelium. I was running and I wiped out. Head over heels, beeper, everything's flying everywhere, my cell phone. I come to rest against this tree trunk and I got this gash in my arm and I'm bleeding and there's all this grit being rubbed into the skin. And my very first thought was, gee, I hope my endothelial cells activate. I don't want nitric oxide. I want superoxide. I want my vessels to constrict to staunch the bleeding. I want endothelial adhesion molecules to be elaborated in chemokines to allow white cells to come in and gobble up this debris. I want my endothelium to activate because I'm experiencing trauma or focal infection. And this is adaptive. The problem is when our patients are dealing with pseudo-infection of the artery wall with oxidized lipids, and they have endothelial activation, that is, of course, dysfunctional, and we need to measure and resolve endothelial dysfunction within the vascular wall. We want the nitric oxide synthase to be converting arginine to nitric oxide. If it's not doing that, if there's a high ADMA-arginine ratio, we're going to deal with the risk factors to lower oxidative stress, to increase the ability of DDH to degrade ADMA, and we can, of course, supplement with arginine to increase the arginine to ADMA ratio, so nitric oxide synthase comes back online, making nitric oxide as opposed to superoxide. Our approach to endothelial dysfunction, we're going to measure endothelial function, or if you don't have an EndoPat, you can simply assume its presence. If the patient has atherosclerosis and hypertension, they probably have endothelial dysfunction. We also have to keep in mind endothelial stresses throughout the day. We measure endothelial tone in the morning in the fasting situation. Then they go out in the world and breathe in bad air and eat bad food, and that could cause endothelial dysfunction throughout the day. So as a general rule, when in doubt, treat the endothelium. Resolve underlying risk factors that inhibit DDH that lead to a buildup of ADMA and a high ADMA-arginine ratio. And we can supplement with arginine in the literature, and I've read about 100 papers on arginine. And again, there was only one that showed a downside. The typical doses are 2 to 4 grams 3 times a day. The patients come in and say, oh yeah, I'm taking arginine. They're taking 500 milligrams. That's nothing. They need to take 2 to 4 grams 3 times a day. We can provide endothelial redox support. The literature supports vitamin C, N-acetylcysteine, lipoic acid, and EDTA chelation therapy. EDTA per se does not improve endothelial function, but EDTA chelation with antioxidant support has been shown to improve endothelial function, resolve infection and inflammation, pharmaceutical support by blocking superoxide formation, statins, ACE inhibitors, ARB, spironolactone, and allopurinol will help us. BH4, tetrahydrobiopterin, is the key cofactor for nitric oxide synthase, which is inactivated by peroxynitrite, which is generated in the presence of oxidative stress. Now, we can't give BH4 in the United States, but BH4 looks an awful lot like folic acid. So 5 milligrams of folic acid or 1,000 mics of methylfolate have been shown to act as BH4 mimics and improve endothelial tone. Nutritional support studies show that omega-3s, Terminalia arjuna, which we'll talk about in the bonus coverage section, magnesium, coenzyme Q, berberine, hawthorn, taurine, and red yeast rice have all been shown to improve endothelial tone. Hormone replacement therapy at physiologic levels, estradiol in women, testosterone in men, will improve endothelial tone. Supraphysiologic levels, though, are maladaptive, but physiologic hormone replacement therapy does improve endothelial tone. Risk factors lead to endothelial dysfunction. Endothelial dysfunction will manifest itself as a rising IMT. IMT is the interface between pathophysiology and anatomy. So we're going to do a carotid ultrasound, and we could see plaque as in a conventional carotid ultrasound, but that's not our target. What we're going to do instead, we're going to use digital calipers to measure the thickness of the Intima-Media stripe. The thickness of the stripe represents your propensity to form plaque right now. And what we can do, we can see that IMT rises with age in ultra-healthy individuals, probably due to loss of protective hormones. The greater the number of risk factors you have, the greater will be your IMT. Large studies have been done of normal individuals without known cardiovascular disease, and we can see how the individual patient relates to their peers. IMT rises with age, and we can we can plug you in to your age mates. If you're at the 5th percentile, that's fantastic. You're blessed. You're not going to have any trouble. If you're at the 95th percentile, you're in trouble. Now, if you're 41, you're not likely to have a heart attack in the near term, but if you have an IMT at the 95th percentile, that means you're pretty much doomed to have trouble later on, because a high IMT reflects your current propensity to form new plaque. Now, we can predict risk if you do not have known cardiovascular disease, and I do your IMT, and if your IMT is low, I can say that your risk of having a heart attack or death over 6 years is quite low. If it's high, that correlates with an increased risk. Different studies have been done in different populations. The ARIC is the atherosclerotic risk in the community study, and that looked at individuals 45 to 64. The CHS was the coronary heart disease prevention study. They looked at risk of heart attack and stroke in seniors. And we can plug our patients in here and predict risk based upon a single measurement of IMT. This slide is about 10 years old, but when I looked, everything associated with an increased IMT was associated with an increased risk of cardiovascular disease. Conversely, therapies that stabilized or regressed IMT were associated with stabilization of the atherosclerotic process and protection against adverse events. So we can look at IMT as a surrogate of the atherosclerotic process, as IMT is the interface between abnormal physiology and macroscopic plaque formation, disease progression, and event rate. As you would expect, the greater your IMT, the greater will be your calcium score. Now, vascular calcification represents your past history, the net effect of all the risk factors that you've borne over your lifetime causing vascular disease. It doesn't reflect your current physiology. IMT reflects your current physiology. It's very difficult to stabilize or regress vascular calcification. Some of that has to do with it reflects not just atherosclerosis, but K2 deficiency, but we can stabilize and regress IMT. In fact, if we put our minds to it, we can stabilize IMT in any patient we want. So I think IMT is a better measurement, but in general, IMT correlates with calcium scoring. Calcium scoring represents your history. IMT represents your current pathophysiology. The greater your IMT, the more likely you are to have coronary disease. The greater the IMT, the greater your likelihood of going from 1 to 2 to 3 vessel disease in patients undergoing non-urgent diagnostic angiography, in individuals with symptomatic hypertension. But of greater importance, the greater your IMT, the greater is your risk for forming a new plaque. So high IMT means that you have an abnormal pathophysiology, you're a plaque former, you're going to generate more plaques, you're going to have more trouble. As your IMT rises, so does the rate of decline in kidney function. In a sense, and I'll apologize to any of you who are nephrologists, the kidney is one big vascular surface. Anything that's bad for the endothelium, that's going to be bad, that'll be associated with an increased IMT, of course, is going to be bad for kidney function. Basically, every therapy that we have that's good for endothelial function and good for IMT is also good for the kidney and vice versa. So a rising IMT correlates with disease burden, but it predicts the formation of new plaques and deterioration in kidney function as well. Now, atherosclerosis is focal. We have lesions beyond branch points. We have impaired laminar flow and downregulation of nitric oxide synthase focally. But IMT is systemic, and we can measure the IMT in the carotid artery, we can measure it in the femoral artery, we can measure it in the coronary artery. It is a common measurement. So here what they did, they correlated carotid IMT with coronary IMT. They did intravascular ultrasound and percent stenosis, and coronary IMT and carotid IMT are quite similar. So we can use carotid IMT as a surrogate for coronary IMT and our systemic propensity to atherosclerosis. Stenoses are focal, IMT is systemic. Now, if you look at individuals who have risk factors, they have greater IMTs than individuals who don't have risk factors. They also have lower endothelial function. So risk factors lead to endothelial dysfunction, lead to a rising IMT. The worse your endothelial function, the greater will be your IMT. That makes sense to us. Now, an IMT at any one point in time predicts future risk. Of more importance to us is change in IMT in predicting risk. This study was done in 50-year-old men that had bypass surgery, obviously a group at high risk for future atherosclerosis. And they found that baseline IMT at the time of bypass was not highly predictive of who was going to have an event and who was not going to have an event. Conversely, change in IMT over time was highly predictive. Those whose IMTs increased were far more likely to have a heart attack or death than those whose IMTs decreased. If your IMT was decreasing, you did not have an event. So the greater the rise in IMT over time, the greater is your risk for an adverse event, because the greater the rate of rise in IMT, reflecting an uncontrolled risk factor burden, worsening endothelial function, rising IMT, your plaque-forming factory is upregulated, new plaque, new events. So we have to move heaven and earth to stabilize, to resolve endothelial dysfunction and stabilize IMT. And we can do that. This gentleman was a dentist. He had hyperlipidemia and a mercury burden. He was a young man. He was only 40. So the pathophysiology had not really been set in yet with irreversibly thickened artery walls. So we got rid of the mercury, we dealt with the lipids, and you can see his mean and maximal IMT improved. KH had Lyme, and his Lyme would wax and wane, and we noticed that his IMT would be worse during time periods where his IMT was worse when his Lyme was worse, because Lyme leads to inflammation, inflammation leads to oxidative stress leads to endothelial dysfunction, you're going to get a high IMT. So the key here was to control his Lyme. Most of my patients are seeing me as their fourth and fifth cardiologist. Their revascularizations have not worked, and that's why they're seeing me. So JS had a couple bypasses. She was no longer operable. She had persistent angina. She came to work with me, and we noticed over the first year her IMT increased. And that is not unusual, because it takes time to turn a ship around. If you're 65 years old and you've got hyperlipidemia and a heavy metal burden, an organic pollutant burden, and high lipoprotein A and high homocysteine that the other guys have not addressed, it takes time to turn things around, and of course we did. And then we got a little complacent here because she was doing so well and her IMT rose a little bit, so we had to, regain our discipline and keep working on risk factor control. David Bobbitt is the best patient in the history of the world. And we'll talk about David Bobbitt in a little bit, but he also increased his IMT the first year, and then we saw a steady decrease. So it takes time to turn a ship around. Now, David Bobbitt lives in Dublin, and I see him 4 times a year. And I'd like to say he comes to the United States just to see me, but he comes here on business. He sees me. He sees a bunch of other integrative practitioners. He's become kind of a connoisseur of integrative medicine. And he had a stress test at the Cooper Clinic, and he passed it. He went 10 minutes and it was normal. And they told him, you're fine, don't worry about heart disease. But he wanted more. He wanted to know whether he had early disease. So he had a calcium score that came back high at about 900. That led to a heart cath. I would not have done that heart cath, but they did that heart cath. His right coronary artery was closed. The left descending and circumflex looked good. He had an elaborate left to right collateral flow network because he was athletic. So he had closed an artery and compensated with collaterals. So the stress test was not a false negative. It was a physiologic true negative, but it was an anatomic false negative. So we had atherosclerosis. And it was compensated. So of course, this is an indication to work on risk factor reduction. So Mr. Bobbitt set his mind to understanding all the factors that cause atherosclerosis. And he worked really hard and had me work really hard. He really wanted to get his LDL particle number low. Now, in primary prevention, 1,000 is good. In secondary prevention, 700 is good. Mr. Bobbitt, he wants to get down to about 300. So we were using a lot of methodologies to lower his LDL particle number, and again, his IMT was improving. And then all of a sudden, June of 14, it spiked. Now this didn't make any sense because his LDL particle number was low. What was going on to cause his his predisposition to plaque formation to suddenly increase was because his doctor, who happened to be me, was practicing brain-in-the-box lipid control. We were pushing so hard to lower the LDL, we failed to consider the side effects of our lipid-lowering therapies. Now, he was on a statin, and we know that that leads to CoQ deficiency, testosterone deficiency. He was supplemented. He was on B6. He was on niacin, and niacin leads to B6 depletion. He was on phenylfibrate that lowers trimethylglycine. So this is going to be compromising homocysteine metabolism and compromising the methyl cycle. So basically, I was knocking out multiple steps in the methyl cycle, and I was blocking homocysteine metabolism, and I was lowering his SAMI to SALI ratio, and that leads to oxidative stress and atherosclerosis. That was my mistake. So anyways, we corrected that mistake, and his IMT is now declining again. Now, David Bobbitt he doesn't mind, obviously, me using his name. He's just a really neat guy, and he has founded a foundation, the International Heart Disease Association of Ireland, and his position is that everybody, once we hit middle age, ought to get a calcium score to raise our level of alertness that we might have atherosclerosis, because most of the people in Ireland who die of heart disease just die suddenly. So if everybody gets a calcium score, you know what's going on. Now, a high calcium score doesn't mean you have to have a heart cath, but a high calcium score means that you've got a problem and you need to address it. So he has websites, ihda.ie, and he produced a movie called Widowmaker, The Widowmaker, and you can go to widowmakerthemovie.com and learn more about David Bobbitt, a really neat guy. So we have to guard against brain-in-the-box lipid control. High-dose statins lead to CoQ deficiency, testosterone deficiency, erectile dysfunction. We need to address this. So I was practicing brain-in-the-box lipid control. I was focusing only on the LDL number. I forgot to consider the nutritional consequences of drug therapy. Every allopathic drug we use has a nutritional downside, and we need to deal with that. Otherwise, we're going to control symptoms and control one or two signs and then create new disease states. So when the American College of Cardiology says there's no role for nutritional supplements, of course, they're wrong. Our drugs lead to nutritional deficiency that lead to new diseases. We can use these drugs. We must be aware of their nutritional consequences and take corrective action. Then the patient gets all the good without the bad. So what factors predict IMT progression? This study was done in Scandinavia. High blood pressure was predictive. Hair mercury, whether you were taking lipid drugs, I think that would be a surrogate for hyperlipidemia. Dietary iron, pack years, which would be a surrogate for cadmium, and age. Factors these factors predicted change in IMT. The same list of culprits are age-adjusted predictors of high oxidized LDL. Hair mercury, urine mercury, nicotine, which would be a surrogate for cadmium. Copper and iron intake, because these high copper and high iron act like lead and cadmium in stimulating the Fenton reaction to convert superoxide and peroxide to hydroxyl. The only thing that was protected was vitamin C and antioxidant. Now, factors predicting an increase in 2-year IMT. High copper, smoking, for cadmium, and the aromatic hydrocarbons cause oxidative stress, low selenium, and high LDL, and there's a synergy. 2-year progression is if your LDL is high, you're more likely to progress if you have high copper than low copper. Same thing with high iron or high ferritin, because LDL is a problem, but oxidized LDL is far more of a problem if you have high pro-oxidant copper and iron. You're going to get more LDL oxidation, you're going to get more endothelial dysfunction, you're going to get more IMT progression. Here we have high copper, high LDL, low selenium, far more progression than high copper, high LDL, high selenium, because selenium would be antagonizing the selenium supporting glutathione peroxidase, so it's supporting our annexin defenses to sort of neutralize the copper-induced oxidation of the LDL, less endothelial dysfunction, less IMT progression. That all makes sense. And again, the key is to block lipid oxidation. The most important predictor, serologic predictor of an adverse event over time would be a high oxidized LDL, because a high oxidized LDL reflects oxidative stress. High levels of oxidative stress drive forward all the other maladaptive upregulated pathways that characterize atherosclerosis. I was giving a talk to another group, and afterwards this lab guy came up to me and said, would you be kind enough to send in some serum samples, because we have a new measurement of oxidized LDL and we want to compare ours to the Swedish gold standard. So we gathered up some patients and we sent in their serum specimens to get oxidized LDL, and some of our patients were high, a few of our patients were low. And of particular interest is subject 27, then a 60-year-old marathon running physician who thought he was taking pretty good care of himself, and I had a moderate elevation in oxidized LDL. So I changed my diet, I changed my supplement program, because I don't want a high oxidized LDL. I don't want to become a patient. Let's talk about cholesterol. Now, we need 800 milligrams of cholesterol a day for cell membranes, for vitamin D, for bile salts, for steroid hormones. So it's key that we get 800 milligrams a day for normal homeostasis. So we can get cholesterol in our diet, but if dietary cholesterol is insufficient to meet our needs, the liver will generate cholesterol. Now, cholesterol is water and blood insoluble. It's a waxy substance. So what Mother Nature does, she binds cholesterol to apolipoprotein B100 to form water-soluble LDL, and its job is to ferry cholesterol from the liver to the cells to meet their needs. And of course, we have mechanisms to return LDL back to the liver, and one mechanism is the HDL particle. Less than the cholesterol loads up cholesterol ester into the HDL, takes it back to the liver for catabolism. Now, this enzyme is poisoned by heavy metals, and if we depoison people, less than the cholesterol activity will improve and cholesterol may fall, and we can stimulate LCAT with unsaturated phosphatidylcholine. And we can use unsaturated phosphatidylcholine not just to lower lipids, but to regress atherosclerosis. And we'll talk about this mechanism in the bonus section. The most important determinant of your serum cholesterol level is the level of expression of the LDL receptor in the liver. Every cell in our body has an LDL receptor. That's the only way it can bring in LDL. Your serum cholesterol is controlled primarily by the level of expression of the hepatic LDL receptor. Now, the synthesis and expression of the LDL receptor is related to the perceived cellular need for free cholesterol. So if the cell needs cholesterol, it's going to express an LDL receptor. If the cell has enough free cholesterol, it will withdraw the LDL receptor. What are the factors that determine the degree of expression of the LDL receptor? This is a complicated biochemistry, and I'm going to present it now, and I'm going to repeat this in later aspects of this presentation. All of our cells have a sensor for free cholesterol called INSIG. When there's adequate free cholesterol in the cell, INSIG sequesters SREBP and SCAP in the endoplasmic reticulum. When INSIG senses there's not enough free cholesterol in the cell, it lets go, and sterol regulatory element binding protein will then be modified by SCAP, sterol regulatory element binding protein cleavage activating protein, snips off a few amino acids so SREBP can translocate to the nucleus, bind the SRE, the sterol regulatory element, which is the promoter site for transcription of the LDL receptor. So if we have high cholesterol, we will not transcribe the LDL receptor. If cholesterol is low, SREBP binds to the sterol regulatory element, and we're going to make LDL receptors to bring cholesterol into the cell, and we're going to make HMG reductase to make more cholesterol. So we're going to generate cholesterol, we're going to pulse cholesterol into the cell only when we need cholesterol. So we have a negative feedback system. So in a non-oxidized, non-inflamed situation, our cells cannot be overfilled with cholesterol. Now, this mechanism can be bypassed because INSIG is measuring free cholesterol, not oxidized cholesterol, not esterified cholesterol, and if the LDL is oxidized, it will be phagocytosed by macrophages. But in a normal resting situation where we're free of oxidative inflammatory stress, our cells will not overfill with cholesterol because we will not express LDL receptors if we don't need cholesterol. Now, cholesterol level and future mortality. we as cardiologists sort of vilify cholesterol as the cause of heart disease. Is that really the case? But again, we need 800 milligrams of cholesterol. So if it's something that we need, how can it only be deleterious? It was shown years ago in 1971 in Japan and confirmed in the US that the risk of cerebral hemorrhage is inversely related to serum cholesterol. The lower the cholesterol, the more likely you are to bleed in the brain. In heart failure, clinical outcome is inversely related to cholesterol level. So the greater your cholesterol, the less likely you are to die. Why is that? Well, LDL cholesterol will scarf up lipopolysaccharide. When we have heart failure, we get leaky gut from bowel wall edema. Lipopolysaccharide enters the circulation, leading to further inflammatory and oxidative stress. Thus, cholesterol is protective in heart failure. So cholesterol's not, in times, cholesterol is our friend. It's not always deleterious with respect to cardiovascular disease. So that led to this study in 1992 done by the NIH. They analyzed 19 prospective cohort studies with 9 to 30-year follow-up. They looked at cardiovascular death rate, overall death rate, and death related to non-cardiovascular disease conditions. And they determined the optimal range for cholesterol with respect to all-cause mortality was 160 to 199. So we're going to look at your relative risk for having for cardiovascular death or overall death in relation to if you were below 160, mildly elevated between 200 and 239, and markedly elevated above 240. And what they found, red, we got it for total mortality, we got a bell-shaped curve in men. Red is in men. So as your cholesterol rose, your overall mortality increased, but again, with low cholesterol, you have an increased mortality. There was no bell-shaped curve in women. There was no penalty in women with respect to total mortality, with respect to cardiovascular disease, with respect to total mortality in women. Now, in cardiovascular disease, risk rises minimally with a high cholesterol in women. It rises markedly with men. But if we look at non-cardiovascular mortality, basically, the greater your cholesterol, the better you do. The lower your cholesterol, the more likely you are to die. So hyperlipidemia does increase cardiovascular mortality, particularly in men, less so in women, but and overall mortality to some degree in men, but hyperlipidemia also seems to be protective against non-cardiovascular mortality. Conversely, low cholesterol is associated with an increased risk of non-cardiovascular mortality. Now, why would that be? Some of us have genetic hyperlipidemia. Why would Mother Nature give us hyperlipidemia if it's going to cause cardiovascular disease? Well, we need to remember that Mother Nature never makes any mistakes. I trained at the University of Cincinnati. We had a large population of kids with sickle cell disease. And this is a miserable disease back then, 40 years ago. These kids would come in, they're in sickle crises, their hemoglobins would go down to 6, they would become habituated to narcotics, a miserable, horrible disease. And these were all good-looking kids. Like, they had the whole world ahead of them, except they're going to be dead before they're 25, because back then we didn't have very good therapies for sickle cell. And I was sort of thinking about this one day, and I was asking, this is genetic disease. Why would Mother Nature do this? Why would it create a group of people who were doomed to die before they reached the age of reproductive health? And my attending, who was an African American, said, these kids really aren't doomed. They're blessed, because if you have sickle, you're resistant to malaria. And whole societies in Africa would be wiped out by malaria. So if you had sickle disease or sickle trait, you survived malaria and passed on those genes. So having sickle trait was of great advantage to you in the times of malaria. Now we've drained the swamps, we don't have malaria in the United States, so sickle cell is an adverse condition, but it was a good phenomenon at one point in the development of mankind. Could hyperlipidemia share that characteristic? Could hyperlipidemia be of value to us in certain conditions and deleterious only in the situation of modern man, where our lipids are being oxidized by overwhelming free radical stress that Mother Nature never anticipated? What are our natural predators? Lions, tigers, and bears? Well, oh my, you would be wrong. Natural predator is infection. Infection changed Yersinia changed the landscape of Europe far more than did Henry VIII, Napoleon. or Mussolini. More souls were lost due to the Spanish flu in 1920 than were lost in the trenches in World War I. The predator of man, the natural predator of man, is infection. Whether you believe in creation or Darwinian evolution, we have been evolving on the planet for 4 million years, and we've evolved elaborate mechanisms to sense and deal with infection because infection is our natural predator. Now, when we have an infection, we're going to experience oxidative and inflammatory stress. And one thing we're going to do is upregulate HMG reductase, because we need cholesterol. Because we're going to make all these white cells, we need cholesterol for the cell membrane. So an upregulation of HMG reductase is physiologic. Now, we need more than white cell membranes. The white cells need bullets. They need superoxide to kill the microbes. So in this process of generating cholesterol, we also generate isoprenoid molecules that activate Rho kinase that puts NADPH oxidase together. NADPH oxidase is the key generator of superoxide as we mount a response to infection. Our white cells are cranking out superoxide. We know that superoxide will go into hydrogen peroxide to lead to nuclear factor kappa beta translocation to make more inflammatory cytokines. So our response to infection, we increase HMG reductase. We're going to make more superoxide bullets. We're going to translocate nuclear factor kappa beta. And of course, we're going to make more cholesterol. So the response to infection, upregulate HMG reductase, and we create free radical species, inflammatory cytokines, immune system upregulation. We have endothelial dysfunction, but that's actually endothelial activation when we're fighting a real infection, and hyperglycemia, because the white cells need sugar to fuel themselves as they battle this infection threat. Now, NADPH oxidase will upregulate, nuclear factor kappa beta will translocate, another inflammation amplification pathway, activator protein 1 increases, NRF2, which codes for antioxidant detox molecules, are shut off. We don't want antioxidants, we want superoxide because we're at risk of being overwhelmed by the bacteria. We need to make superoxide to kill the microbes. So in experimental models where you administer lipopolysaccharide to animals, you see increase in cholesterol and LDL, increased triglycerides. You see a decrease in hepatic LDL protein expression because we want hyperlipidemia. We don't want the liver to pull LDL back into circulation. We see more PCSK9, which we'll discuss later, degrades the LDL receptor. So in response to inflammation, the liver becomes a lipid generator to shunt lipids to the periphery for our white cells to use to make new cell membranes to help fight the infectious battle. Now, we have this feedback system to prevent cells from overfilling with free cholesterol. But when we have these inflammatory pathways upregulated, what happens is we begin to esterify cholesterol within our cells. INSIG and SCAP are going to sense free cholesterol, not cholesterol ester. In response to inflammation, we begin to esterify the cholesterol within the cells to kind of store it up for this infectious winter that we're going to be dealing with. So free cholesterol falls, our negative feedback system is bypassed, so we're going to, in the presence of inflammation, we're going to load up the cell with cholesterol ester more than we would need in non-inflamed, non-oxidized conditions. And this, of course, leads to overfilling of cells of the intima with cholesterol, leading to foam cell formation and atherosclerosis. The serine kinases that degrade ICBA to allow nuclear factor kappa beta to go to the nucleus will also lead to serine phosphorylation of the insulin receptor substrate 1. Now, when it is tyrosine phosphorylated, that improves insulin sensitivity. Conversely, when it's serine phosphorylated, as in the situation of legitimate infection or abnormal oxidative inflammatory stress, serine phosphorylation leads to insulin insensitivity, leading to hyperglycemia. This is why sugar rises with infection, and this is physiologic because your white cells need the sugar to fight infection. It's maladaptive in the situation of modern man when the inflammatory and oxidative cues that we're experiencing don't reflect infection, and this leads to hyperlipidemia, oxidative stress, hyperglycemia. Oxidative stress is our body experiences oxidative stress as another infection. Primitive man, when would he experience oxidative stress outside of infection? So oxidative stress, triggering this response to perceived infection, we get inflammatory stress, endothelial dysfunction, immune dysregulation, hyperlipidemia, hyperglycemia. We need to quell oxidative stress, which Mother Nature interprets as, yep, another infection. So oxidative inflammatory stress reflects infection. Our problem is we're not really dying of infection anymore, but modern living creates all these phenomena that lead to the elaboration of free radicals and inflammatory cytokines. Our high sugar, our high fat diet, belly fat is inflammatory, environmental toxins, leaky gut, infection and allergy. All these phenomena of normal living are causing overproduction of free radical species and inflammatory mediators. And then, so we have this missed decision to increase cholesterol production. We get hyperlipidemia, we get oxidative stress, we get insulin insensitivity, we get endothelial dysfunction, we get atherosclerosis. So we can block this with statins, and this is why statins are so effective. Now, statins don't do away with all these underlying causes of hyperlipidemia and hyperglycemia and oxidative stress, but they can neutralize them. And that's why statins are pretty much universally effective in patients with cardiovascular disease, because while you're not dealing with the underlying causes, you're mitigating the consequences. You're not just blocking the generation of cholesterol, you're blocking the generation of superoxide and other inflammatory mediators. And that's why they're helpful. Now, when we are using a statin, we say we're doing it to lower cholesterol, but we're really doing it to block NADP oxidase generation of superoxide. So we're really using statins not for lipid reduction as much as to deal with oxidative stress. So you can look at all these beneficial effects in the literature on statins. They're called pleiotropic effects, as if these are like cluster bombs that are breaking up into all these other little molecules and doing all these other little things. But that's really not the case. It's just doing one thing. We have immune modulation with statins, and this all has to do with blocking HMG reductase and blocking the generation of superoxide. So it's not like there's the mother of all statins. They're doing a whole bunch of different things. They're simply blocking the generation of cholesterol and blocking the generation of reactive oxygen species. And it works. Here was a study. They took people that had a heart attack and sent them home on a placebo or an HMG reductase inhibitor, and you're going to follow them over time. Event rate over time over 7 years, 10.4% with placebo, 5.7% with the HMG reductase inhibitor, 45% risk reduction. We cannot argue against that. What was the HMG reductase inhibitor they used? It was Reggie's rice extract. We use drugs to lower HMG reductase, but if we do it with a nutraceutical, we can lower cholesterol, we can lower superoxide, we can have the same effect on downstream inflammatory and oxidative mediators, the same effect on outcome. So we don't have to use drugs, we can use nutraceuticals to block this pathway, which is upregulated when Mother Nature misperceives the oxidative inflammatory cues of modern living as infection. And we will have a section on nutraceutical approaches to HMG reductase inhibition. Reggie's rice, oil of bergamot, amla, and delta-tocotrienol can all be used. Berberine also will block superoxide generation by blocking the assembly of NADPH oxidase. So this is an in vitro study. Lipopolysaccharide upregulates NADPH oxidase, and you make superoxide. This is blocked with berberine. So berberine inhibits assembly of NADPH oxidase, lowers superoxide, another good reason to put your patient on berberine. We'll talk about berberine later. We have a section, doctor, I can't take a statin, so what do? So you can supplement to improve tolerance. We know that statins deplete CoQ, they may deplete D, they deplete testosterone in men. So if you can put them on a lower dose of the statin and supplement with CoQ and testosterone. SOCO1B1 is a hepatic pathway that mediates the degradation of many of these statins. The statins that are least sensitive to downregulation here are pravastatin, rosuvastatin, or fluvastatin. One thing I've been doing is using rosuvastatin every other day. And just about everybody can tolerate 5 milligrams of rosuvastatin every other day, and we get a lot out of that with good tolerance. There's something about rosuvastatin that makes it work well every other day with a long half-life. Berberine will increase the efficiency of statins, drug or nutraceutical, by about 50%. So I'll use berberine, and that will allow me to decrease the dose of the statin drug to improve tolerance. We can use red yeast rice extract, oil of bergamot, amla berry extract, gamma and delta tocotrienols. More on that in the bonus coverage section. Nuclear factor kappa beta. You know, everything that causes inflammation and oxidative stress is somehow involved with nuclear factor kappa beta. All of our mononuclear cells have threat receptors. When they're ligated, we get a chain reaction of serine kinases that stimulate ICPA that stimulate ICPA kinase to degrade ICPA to shoot nuclear factor kappa beta into the nucleus. So we want to block nuclear factor kappa beta. Nuclear factor kappa beta is our friend when we're fighting a real infection. It is not our friend when we're dealing with atherosclerosis and heart failure. So let's look at nuclear factor kappa beta activation expression in stable versus unstable angina. 102 consecutive patients undergoing angiography. 19 had unstable angina, 83 did not have unstable angina. We're going to assess for activation of the nuclear factor kappa beta pathway. And what you'll see, those with unstable angina versus stable angina had greater expression of nuclear factor kappa beta. That makes sense. They have oxidative inflammatory stress, more nuclear factor kappa beta translocation, more inflammatory cytokines, more plaque destabilization, more likely to have unstable disease. Now, if you expose the cell to tumor necrosis factor alpha, that will increase the expression of ICPA kinase. It'll degrade ICPA. Nuclear factor kappa beta goes to the nucleus, and you're going to make more TNF alpha. TNF alpha leads to more TNF alpha via the nuclear factor kappa beta pathway. Tumor necrosis factor alpha also will activate mitogen-activated protein kinase that activates one of the serine kinases, JNK, C-Jun N-terminal kinase, that leads to activator protein translocation, more tumor necrosis factor alpha. There are many pathways through which Mother Nature amplifies the inflammatory response. Defense against infection is so important that there's many means by which a threat agonist will cause our body to respond by making more anti-inflammatory mediators. Thus, giving one drug or one supplement to block inflammation doesn't make any sense because we have redundant inflammation amplification pathways. So there's going to be a role for using more than one agent to block inflammation. Now, we've talked about the use of drugs. ACE inhibitors and ARBs block NADPH oxidase. Beta blockers will help block catecholamine autooxidation, which leads to oxidative stress. And we've talked about keeping nuclear factor kappa beta at bay. ACE is upregulated within the intima in an unstable coronate situation. Ligation of ACE leads to nuclear factor kappa beta translocation. And we get COX-2, PGES2, matrix metalloproteinases, plaque rupture. We don't want to see ACE in the artery wall in the patient with active atherosclerosis. Now, when we're talking about ACE inhibitors, only use lipophilic agents. Flow-mediated vasodilatation in this study was 11% in normal people, 6.2% in controls. And then you'll treat them with different agents. Quinapril, which like ramipril is lipophilic and gets into the artery wall, will improve flow-mediated vasodilatation. Losartan, an ARB, gets into the artery wall, blocks the type 1 angiotensin receptor. It improves endothelial function. Amlodipine, which is a calcium blocker, does not improve endothelial function. Enalapril, which is a hydrophilic ACE inhibitor that does not get into the artery wall, will lower blood pressure but not improve endothelial function. It's really kind of stupid to use a hydrophilic ACE inhibitor. Why not use a lipophilic ACE inhibitor? It will lower blood pressure, but it will also get in the artery wall. So whenever you have the option, switch the patient from a hydrophilic ACE inhibitor to a lipophilic ACE inhibitor, an ARB. From a practical point of view, this is quinapril, ramipril, or an ARB. So you're going to lower blood pressure and improve endothelial tone. Why waste that blood pressure, when you could lower that blood pressure and improve endothelial tone with a lipophilic agent? Now, so here we're going to look, will blocking angiotensin 2, is it additive to statin and aspirin therapy in quelling atherosclerosis? So here we take patients with who are on with cardiovascular disease, they're on an aspirin, you give them a atorvastatin, IL-6 falls. Then you add to aspirin statin therapy quinapril, a lipophilic ACE inhibitor, or irbesartan, a lipophilic angiotensin receptor blocker, you get a synergy. So statin adds to aspirin, ACE inhibition adds to aspirin and statin therapy. If you look at monocyte adhesion molecules, it falls with atorvastatin. It falls more by blocking angiotensin II within the vascular wall. ARB effects on vascular oxidative status. 47 stable coronary patients with prior revascularization, all on aspirin, 90% on statins. None were hypertensive, none were on ACE inhibitors or ARBs because they weren't hypertensive. Baseline labs treat them over 12 weeks with an ARB or irbesartan. Periodic lab studies are carried out. Now, what you see, neutrophil superoxide generation is unchanged with placebo. It drops with ARB therapy. Lag time to LDL oxidation, that is the resistance of the LDL particle to oxidative stress, improves. T-bars, which is a measure of lipid peroxides, falls. Monocyte adhesion binding, a measure of endothelial activation, falls. These patients weren't hypertensive, but they had atherosclerosis. So by definition, they had excessive angiotensin II within the vascular wall. If we block that, we improve endothelial function, we lower oxidative stress, and we will improve outcome. Tissue-specific ACE inhibitors or ARBs, if the patient cannot tolerate the ACE inhibitor because of a cough, are of value in patients with coronary disease and risk factors because they will improve endothelial tone. And this has been shown to provide protection against new onset cardiovascular disease, diabetes, and diabetic complications. That was the HOPE study. Complications, new events following a heart attack. The Quo Vadis study took people that were scheduled for bypass. They put them on quinapril, kept them on it for a year. 80% reduction in first-year post-bypass event rate by improving endothelial tone. In angioplasty and stent patients, vessel patency is better maintained, restenosis is decreased, progression of proteinuric renal insufficiency is blunted. Anything that's good for the endothelium is good for the kidney, likely beneficial in angiogenesis. A lipophilic tissue-specific ACE inhibitor is appropriate in all of our patients with heart failure and coronary artery disease. Catecholamine autooxidation. If we can't break down catecholamines with COMT, that's catechol-methyltransferase, and that's how we degrade catecholamines via methylation. So the cofactors are magnesium and physiologic SAMI to SALI ratios. If we have high homocysteine, we're going to have a low SAMI to SALI ratio. We're not going to be able to break down catecholamines. We get hypertension, arrhythmia, and stress intolerance. If we can't break down catecholamines via methylation, they auto-oxidize and generate peroxide and superoxide and hydroxyl. We don't want to see that. Will beta blockers add to ACE inhibition with respect to downregulating the Th1, Th17 skewed immune response to atherosclerosis? The ratio of interferon gamma to interleukin 2 would be a ratio of Th1 and Th70 to Th2 and Treg. It is decreased with beta blockers. ACE inhibition doesn't help. Combination of beta blocker and ACE inhibition helps. IL-6 falls with beta blocker and ACE inhibitor and with combination. We will, if you have heart failure, the preferred beta blocker is carvedilol because carvedilol has an antioxidant function as well as a beta blockade function, and TNF-alpha and IL-6 fall when carvedilol is added to standard therapy in patients with heart failure. So these drugs do serve a purpose by lowering inflammation and lowering oxidative stress. Here's a cool study where they looked at the rate of change of carotid IMT with lipid reduction. And even though they lowered the LDL, they didn't solve the problem because cholesterol itself is not the entire problem. IMT increases. If you do lipid reduction plus metoprolol to block the contribution of a high adrenal tone on vascular disease, there was a regression of carotid IMT. But when your carotid IMT is regressing, you're pretty much free of adverse events. Now, Th1 T helper cells have an adrenal receptor. Th2s do not. So you have a lot of adrenaline, you're going to go towards Th1. Th1 drives atherosclerosis. So beta blockers are useful not just in symptom control and blood pressure and heart rate control, they have an anti-atherosclerotic effect. And we want to block catecholamine autooxidation as that causes oxidative stress. So there was a synergy here between lipid reduction and metoprolol, which is lowering oxidative inflammatory stress in this situation. This presentation, Integrative Cardiology for the Chelating Physician, is actually 9.5 hours in duration. So what I've decided to do for the web-based version of this talk is to divide it into 5 parts. You've completed part 1. Now please grab another cup of coffee and move on to part 2, which begins with a discussion of cardiorheumatology.